Thank you, Beth, Tom. Need to, of course, Dr. Keeney and Sharma for inviting me to speak. I'm always excited to talk about our different educational projects. I've been at the Mount Sinai Cath for more than 6 years now, and I'll jump at any opportunity to talk about what we're doing. So first, I want to zoom out and talk a little bit about where is innovation happening right now in patient management. Of course, you can't really get away from artificial intelligence. It's in our phones, it's on the news, it's here at this table today. We have ambient AI was mentioned. It's just listening in the background, helping you write notes. That speeds things up. We have epic messages. They're being drafted. You just have to verify them and send them to the patients. We have agents like Sophia, to my left, helping with patient-facing encounters. Then we have some more traditional work, such as just the unification, putting scheduling on Epic, just the fact that a patient can go into my chart and check in, the fact that they can check in without speaking to somebody at the desk. They have appointment, medication reminders, even concepts like remote patient monitoring. There's a lot of different areas where innovation is happening right now. Of course, AI is in the news, but I'm going to put it under the trust but verify category. So that ambient charting, you can't just save that. You have to read what it wrote. You can't trust it, not yet. That Epic's message, they're not automatically being sent. You have to read it, verify it, put your name under it and send it. And the same goes for Sophia. You saw Grace review that call today. If that was a real patient call, she would look at every one of those responses in the clinical questionnaire, and only then can she verify and then put her name under it, because it's going to be her, not Sophia, that gets in trouble if something goes wrong. So what do you do when you have a question? Personally, maybe it's home improvement. Maybe I'm looking for a baby monitor tablet, a new phone case. These are actual examples, not very exciting. But the point is, I Google it. I go to ChatGPT. I go to Gemini. I used to be a little skeptical. I really like what it's outputting now. But what happens if you have a work question? There's a patient with a contrast allergy, right? What's the NPO we tell patients before they show up? Complications management, same-day discharge. All of this, ChatGPT, Gemini, they're going to very confidently and instantly give you an answer. It's not the right answer, but it's going to give you an answer. So an example right here, ChatGPT 4.0. So this is their most recent and I guess cheap most recent model. You ask cardiac cath NPO, great, 6 hours. It's an answer. It's not the one we're supposed to give our patients. How about cardiac cath patient contrast allergy protocol? It got 3 of the medications right, and that patient will probably be doing okay, but that's not what we're supposed to be doing. That's not our protocol. So it's been growing very rapidly. This is showing residents taking medical specialty license exams in Israel, just the change between GPT 3.5 and 4. By 4, in certain areas, it's able to match or exceed the answers given by these residents that have prepared for specialty exams. That's very impressive. That's GPT-4. The example I just gave, giving us the wrong data, was 4.0, which is a lot better. So it doesn't matter if it gets to 100%, because it doesn't actually know the data that we need to know. It knows general data. So institutional protocols, for example, that NPO instruction, it's rigid, it's structured. There's no room for deviation. Only special circumstances. And we only make changes based on, for example, Dr. Sharma's talk, the top 10. Those trials coming out, those are the only real reason, that and local improvement projects, that we might change how we do things. But we're not just going to suddenly have one patient discharged at a certain time, another one discharged another time, NPO varying, medications varying. That's not how medicine is delivered. These large language models are trained on old data, textbooks written by people that are no longer here, but they're also trained on new guidelines. It's a bit of a mix. So it's probabilistic by definition, as opposed to deterministic. It's not going to give you the same answer every time. You might ask it, or you might ask it the same question. It will give you similar but different answers. That's not good enough for medicine. So the good news is educators, courses, peer-to-peer education, life cases, and of course a little self-shout out to this conference. We're all here to stay because we're providing information specific to how we treat patients, not an average and not an aggregate of the entire world. Still, there's an opportunity to improve, and I'm going to go back to the title and zoom back in. So what have we done in the cardiac cath lab in projects trying to help with patient management? You've heard about peri-procedural care coordination, Sophia, how she's handling calls before patients come up for their procedure. We have STEMI management with STEMI Cath, and you heard that from Derek. But that's already been discussed. So I'm going to cover provider education in our cardiology apps, Cath Lab Aid project, as well as the digitization of our catheterization protocol. So it really is quite simple, but I'll show you how that's pretty significant later on. So in the past, you used to have to find this textbook that's updated once a year by Dr. Sharma for a new group of fellows. You would go on the table of contents, hope you can find what you're looking for. Maybe you don't even have the book, maybe you have to borrow it. Now you just go on this website and you're able to search it. So that's already a big improvement. For our Cath Lab Aid application, we're working on the accessibility of information. So this is a project outside in the booth, if you want to talk to him, Mary Glenn. And then Derek had a big part of this as well. It goes into specifically from a nursing standpoint, the pre, intra, and post-procedural instructions for patients going through the cath lab. So if a patient has a contrast allergy, well, there's our actual protocol information, not whatever ChatGPT feels like spitting out that day. And then we have a lot of helpful information like contacts of our attendings, of our NPs, miscellaneous people where you can find my number. And we have little bells and whistles like helpful calculators. There's cardiac output. Maybe that's relevant for MCS, for example. And I want to take just 2 examples out of the 14 that we have. And please do go see that booth for cardiology apps. I'm going to talk about Complicate and MCS Aid. So in cardiologyapps.com/complicate, we have a very extensive compendium of complications in the cath lab. We have all of the complications defined. We have incidents, we have references to read more about it. But the selling point is 55 complications, 880 angiograms. Every single one of them is annotated. If there's a complication, there's a very obvious circle or red arrow pointing right towards it. And this is one example of, it really is sticky. There is an example here where you have a clinical presentation. You have an EKG before and after. You have your angiograms. And then you have a case overview. So what happened in this case? How was it treated? Learning objectives. How can you avoid this in the future? What can be done differently to lower the incidence of this particular complication? And with 55 examples, there's really a wealth of information there. Just a matter of seeking it out. And then I happened to follow a talk on MCS. So I added MCS Aid. So this is a dedicated application, primarily designed by Gregory Sorrell, about both deciding which MCS device is needed based on the patient status, presentation, and variables, as well as a weaning and escalation algorithm. So if they started out on Impella, maybe it's time to take it out. Maybe they have to be escalated to ECMO, IABP, or vice versa. All of these devices are defined. There's definitions of shock and the different criteria. And there's all kinds of calculators to help make the determinations of whether it's time to escalate or wean. So what are some of the future directions we're taking this? We're going to keep growing our existing library and keep focusing on specific topics. For example, hemodynamic aid. There's an application covering pressure wires, FFR, IMR, CFR, RFR. All of these things will be out hopefully in the next couple of weeks. We're adding new topics via the help of our nurse educators. We have new devices, recent changes in guideline-directed medical therapy, any additional resources. We're trying to increase 24/7 access to these more focused topics. So outside of places like this conference, you still have a resource to draw upon. So just as one example in how much work is left to do, Sophia is amazing, but in the overall patient journey, she's only touching one small part of that. Now we're going to dream a little bigger. For future directions and innovation, ChatGPT is not able to provide us the answers we're looking for, but using institutional knowledge and leveraging the existing applications that we have, such as even the small projects like digitizing the protocol book that Dr. Sharma works on. Well, now we're able to leverage the generative AI of an LLM like GPT, but it's no longer going to give you random answers. It's not going to give you one answer and you a different answer. It's going to draw upon our knowledge and specifically answer. So imagine now you're having a conversation with an AI, but it's trained on our protocols, all of our institutional knowledge. A teacher, Sophia, if you would. You can even think a little further and start creating a lesson plan. Maybe a new hire, maybe somebody moving to a different unit, and you can actually have it create a lesson plan based on specifically our knowledge, not general information. I am co-opting the takeaway points into calls to action. The first is to please utilize the existing tools. There's a lot there. Step one is just to know that it exists. This is a chaotic web of the symposiums, the life cases, the protocols, even CAR-T fit and yellow trials is here. These are all projects that a lot of time and effort has gone into, and you might find one that's really relevant to a topic that you're interested in. Even in this symposium, I can pick out a few of those projects and find a relevant application or something to get more information on. The second is to help guide the implementation of AI. So with Sophia, for example, before she ever spoke to a patient, she went through months of work, training, testing, regulatory in the standpoint of our hospital administration and various DTP teams, but also it had to meet our standards of the nurses that do these calls. And we had to make sure that it was safe before our patients ever spoke to her. And the same goes for any of these other solutions. Ambient AI, for example, I heard. Well, maybe it is good, but it would have to go through strict testing before we're able to safely use it on our patients. And then 3 is a bit of a selfish request, and that is to help increase the availability of data in a digital space. So any of these fancy AI solutions, the only way we can possibly use them is if the data lives digitally. So if there's a piece of paper where maybe schedules are scribbled, we can't use that, for example. So any amount of work you can do to help digitize any of your workflow would be step 1 if you're interested in deploying any kind of solution. So thank you so much.